Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And today we're going to talk about your heart, how to keep it healthy, especially after dealing with COVID, and some new technologies to help your heart if it ever needs it from Northwell Health here on Long Island. My guest today is Dr. Rajiv Jauhar, the Vice Chairman of Sandra Atlas Bass Heart Hospital and Chief of Cardiology, North Shore University Hospital. Dr. Jauhar, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you so much. It's a pleasure to be here. I appreciate the opportunity.
So tell us about yourself and your career path. What made you want to become a cardiologist?
My career path is interesting. You know, I was born in India and I moved to England when I was 6 years old, and we spent a few years in England. My dad was a professor of genetics. And then my grandfather was a doctor, so I always wanted to become a doctor. That was my passion. From people say, they're confused about their career choices. I knew from day one I wanted to be a doctor. And that was not an option. Not an option. It was not it's what I wanted to do from day one. Now, being from an Indian family, it was definitely, my parents definitely wanted me to become a doctor. They definitely pushed a little, but I didn't need much pushing. I went to California, went to college at the University of California. Then I went to medical school at the University of Chicago at Pritzker. Then I went back to San Diego, or UC San Diego for residency, where I developed my passion for cardiology by doing some research and spending time in the CCU. And then I came to Cornell at New York for my cardiology. And then from there, I came to Northwell Health, and I've been here ever since. I think I've been here now 22 years.
Nice to hear that. So let's first talk about heart health as it relates to COVID. Is there a connection? And tell me, if there is, what is the connection?
Well, there's no clear connection. I mean, in other words, what I tell everybody is COVID does not cure heart disease. So the epidemiology, the prevalence of heart disease has not changed due to COVID. And so people can still develop heart attacks. People can still have heart failure. People can still have arrhythmias despite this COVID pandemic. That being said, what we have noticed, however, is that, when COVID was at its peak in early April 2020, people were just too petrified to come to the hospital, were too petrified for preventive care, follow up with their doctors. And so we have seen a surge of heart disease, probably, I repeat, due to the fact that people were not getting adequate preventive care in 2020 and 2021 because of the COVID surge that we had.
So is there, while it's not necessarily a connection with COVID, may there be some connection with the vaccines and heart health? Any side effects from the vaccines that would cause or lend to a heart issue? So
COVID has been shown to cause a couple of things. One is, in some patients, it can cause what's called a inappropriate sinus tachycardia. And by that, I mean your heart just races a lot more than it ever did pre-COVID. And that's been shown. Second thing that we've seen very rarely, however, and I repeat, very rarely, probably easier to get hit by a car walking across the street than to get this, but infection or inflammation around the heart, what we call myocarditis, that has been shown in very, very rare instances, and has also been temporally related with some vaccinations. Although whether there was a direct correlation or not is still very, very unclear. I just want to reiterate that the vaccine is extremely, extremely safe, and it behooves all of us to get that vaccine to reach the herd immunity so we can get out of this mess that we've been in for the last 2 years.
So there has been no connections with the vaccine and blood clots?
There has been no causal relationship between vaccines and blood clots. Patients who get COVID are definitely at increased risk of blood clots. That's clear. They get hypercoagulable, they have increased risk of lung clots and blood clots in the leg, but the vaccine per se has not increased the risk of blood clots.
Now let's switch topics a little bit because Northwell has some exciting news. Northwell's Sandra Atlas Bass Heart Hospital is the first in the Northeast to install the most advanced technology, the cardiac catheterization lab. Can you tell us about that?
Well, cardiac catheterization has been around for decades. And
Yes.
So, as we get more and more precise with our stenting and our angioplasties, visualization is of course of paramount importance. And so we this year and over the next several months will be developing about 9 to 10 new labs for our electrical and our cardiac catheterization procedures. So they'll be the latest and the greatest available in 2022 for that kind of procedure. It will allow the physicians more control of very precise visualization, better imaging techniques, better understanding of the use of physiology during the procedure, so that we know exactly which lesions, which blockages are actually significant versus which blockages are just developing.
So for those that may not know, what is a cardiac catheterization and how is it done? Mm-hmm.
So cardiac catheterization is basically looking at the roadmap of the arteries that supply blood to your heart. So there are essentially 3 arteries that supply blood to your heart. And we actually go into each of the arteries and by injecting dye are able to visualize whether a person has any significant blockages. And
so this new technology, the cardiac catheterization lab that you have, that you've always really had, you're getting more cardiac catheterization labs at Northwell. What makes them different than the one that you had previously?
Well, it's sort of akin to what I call, the original iPhone, right? So the original iPhone, if you look back now 10 years and you look at the original iPhone, you're like, oh my God, did I really use this? But when it first came out, it was amazing technology. And so, over time, we have better visualization, we have less radiation, we have better techniques in terms of imaging and smaller catheters. And so I guess it's a natural progression of the technology that was started in the 1980s. So we have the latest equipment that's available on the market, and we continue to upgrade all our equipment in all our labs on Long Island and in Manhattan to sort of provide the best care for the patients who come through our system.
So when can a person who comes to the hospital expect to have a cardiac catheterization? Is it when they come in with chest pain, or when is it an indication for cardiac catheterization? And can you walk us through specifically what's done during a cardiac cath?
Of course, there's several indications. There are elective and then there's urgent indications. Urgent are if someone's having a heart attack, someone's having crushing chest pain, he comes to the emergency room. We go in, we look at the arteries, look for the blockages and fix them. That's straightforward. The elective ones are, say, I'm now 55 years old. So I exercise X amount of minutes per day. And I've noticed over the last several months that when I exercise to a certain level, I get chest pain. My left side of the heart, that gets better when I stop exercising. So I go see my doctor and I say, look, doc, I'm having this pain when I exert myself and it's relieved with rest. Now, the body is a beautiful organ. So the heart is a beautiful organ. When it doesn't get enough oxygen or enough food, it starts crying for help. So the only way it can cry for help is saying, I'm not getting enough blood because you have a blockage there. And so if I'm not getting enough blood, I get chest pain. And that's what pressure is. So then the doctor will say, well, an angiogram, a catheterization is an invasive procedure. You're very stable. This is not an emergency. Let me do a stress test. And invariably, they'll do a stress test. And what that stress test will show is if a certain part of the heart is getting less blood flow than the other parts. So if you have normal arteries, the blood should flow the same to the whole heart. If you have one blockage or two blockages, then the blood flow through those blockages will be a little less than the rest of the normal heart. And so if you see those blockages on the stress test, then you go for an angiogram. during an angiogram, we usually go through the wrist, and all the tributaries in the heart are connected. So we go through the radial artery in the wrist, and we go up to the heart, go into the arteries to the heart, look for blockages. If we find a blockage, then we're like plumbers. We just we take a balloon, we open up the blockage, and we put a scaffolding stent in to keep that artery open. What that does is it takes that 80-90% blockage, which is having less blood flow, and opens it up to 0%. So now you have normal blood flow. And that's what we do. So don't tell anyone, but we're just plumbers.
From Home Depot.
Hey, listen, sometimes you got to go. Black & Decker is the way to go sometimes.
So when you talk about a stent, what is that? I know sometimes it's an indication for a stent. What is a stent, and why would that be an indication?
So a stent is basically if when you open up a pen, right, and that spring in the pen, that's probably the best schematic I can tell you on a radio without actually showing you a picture. And so basically what it does is we put that stent inside the artery, we open it up, and it serves as a scaffold to prevent that artery from closing on itself, because an artery is a muscle. And so by preventing it from closing, it props it open, it keeps it open, and maximizes blood flow, which is why then you don't get that chest pain anymore.
And can you put a stent in during the cardiac catheterization procedure?
Yes. So, like I said, the cardiac catheterization is basically just a roadmap. It tells us how everything looks. And then depending on the significance of the blockage and the physiology of that blockage, we decide whether to put a stent in or not to open up that artery.
You're listening to Your Family's Health on the voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning all about your heart, how to keep it healthy, especially after dealing with COVID, and some new technologies to help your heart if it ever needs it from Northwell Health here on Long Island, including their new cardiac catheterization labs. My guest today is Dr. Rajiv Jauhar, the vice chairman of the Sandra Atlas Bass Heart Hospital and the chief of cardiology, North Shore University Hospital. So, Dr. Jauhar, another question for you, switching gears again. What is the correlation between cholesterol and heart disease?
Well, there's a strong correlation on the upside. So if your cholesterol is high, and by high, there's a certain breakdown, but if it's above, say, 200, as the marker, the benchmark we use, you're at increased risk of heart disease. That does not mean that if your cholesterol is normal, less than 200, and the subproducts are normal, that you can't get heart disease. What is disconcerting is that about a third of all heart attacks occur in people with normal cholesterols. So what does that mean? That means that there are other factors that play a role in developing heart disease or heart attacks, and not just cholesterol alone.
And what might those factors be?
Well, Dr. Cook, we have modifiable and non-modifiable risk factors, right? So we're born into a family. We have the family history of heart disease. We can't change that. We are male or female. We can't change that. We can't change the genetics of that, right? And our ethnicity and the risk factors associated with that ethnicity, we can't change. So those are non-modifiable. That I can't worry about. What I can worry about is what I can modify myself. So high blood pressure, diabetes, or controlling the sugar, smoking, which is probably the worst thing, vaping, which is equally bad. So, people, I have so many patients tell me, well, doc, it's okay. I just vape. Like, vaping has as much nicotine. It can damage the lungs. Its risk of a heart attack or heart disease is about 58% higher for vapors than non-vapors. It's a lot. Sedentary lifestyle, obesity, terrible diets. These are all, there's many others, but these are some of the main ones that we can control. Stress levels. We all work intently, in our jobs, and we are all type A personalities. We don't know how to chill, and I think it is so important in 2022, after all the hell we've been through in the last 3 years, that we have to find ways to mitigate our stress. And stress is a huge, huge problem in our society. along with the other risk factors.
So would it be fair to say that if I do have an elevated cholesterol, I have a propensity for being hyperlipidemic or have a high cholesterol level, would it be fair to say if I change my diet to maybe more of a vegan diet or decrease my animal fats in my diet, does that significantly change my cholesterol level? And could I actually reverse the chance of having heart disease or heart attack?
Diet plays a huge role. It depends on your cholesterol level. I think a vegan diet is a terrific diet. There's definitely data to suggest that people who are on a vegan diet can regress some of the plaque buildup. Significantly, probably not. The percent of reduction of plaque is probably not there, but the architecture of that plaque will dramatically decrease your risk of a heart attack. So that's what's important. In terms of what types of diets, I mean, if you look at the data, the diet that's probably, I won't say best, but the diet that's probably best studied is a Mediterranean diet. And it's probably the diet that's easiest to incorporate in someone's lifestyle. You know, unfortunately, we are such a meat-eating society that vegan is probably a little harder for a lot of our society. If one can do it, you know, more power to you. I think it's a terrific way to affect your cholesterol levels. I must say, however, that cholesterol levels are not purely just diet-based. And so, you know, just because you eat right and eat well does not mean that your cholesterol can't be high. And it's not a testimony that you're a failure. People come in like, you know, so depressed and sad. Oh my God, doc, I'm a vegetarian. I exercise. I'm like, you're not failing an exam. It's not your fault. I mean, sometimes you may need medications. You know, I'm on a cholesterol lowering medication and I exercise 6 days a week.
I mean, is it possible? Because my mom also is, her cholesterol has been over 200 for a long time. And she's on statin medications and she's very active and she doesn't eat a lot of meat. And still, we do not see, right, the dramatic reductions in her cholesterol level. What do you think? Or what do you think is the reason or the cause for that?
Well, you know, like I said, we have things that are non-modifiable, and that's our genetics. So if she has a strong family history of hyperlipidemia or high cholesterol, then, you know, she can do whatever she wants, diet-wise, exercise-wise. It's not going to work. You know, I'll give you an example. Myself, right? So my cholesterol ran about 220, about pre-COVID. I was 183 pounds and I was a little chunky. I'm about 5'9", 5'8", and I lost 20 pounds. So I'm like, yeah, you know, I've done a great job. I started really playing tennis 3 times a week. I lift weights 3 days a week. I'm a Peloton dad. I call myself a Peloton dad. I'm on that Peloton all the time. But my cholesterol didn't drop. It literally did not drop. It dropped by 10, 15%. And so now I'm on a cholesterol lowering medication and I'm good with it. You know, that's okay. You know, it's not a sign of failure. It's just my genetics. My mom had it. My dad had it. My grandparents had it. I can't expect that I won't have it.
Right. And so you talk about medications, and I know statins are usually very commonly used for someone who has an elevated cholesterol level. But talk to me about the statins. Are they the first line for patients who have the elevated cholesterol? And talk to me about some of those side effects.
Yeah. So I think in 2022, a statin is the first line. The side effects of a statin are really dependent on the dose and the class effect. So it's usually the muscle aches in the thighs and the shoulders are the classic side effects. Liver enzyme elevation, because it goes through your liver, can be a side effect. It's definitely much worse in people who drink. And so limiting or mitigating alcohol use is probably important. But it's not the only therapy available in 2022. And, you know, we have to tailor our therapies to the individual. You know, most of the studies to date on cholesterol lowering were done with all due respect, in Caucasian white males. And so we don't have any data or much data on people like me who are South Asian from India or African-American women or African Americans or Hispanics, because there's not much data out there.
Sure.
And the therapeutics that may work for me may not work for you, and vice versa. And so I think tailoring care to each individual is of paramount importance.
You're listening to Your Family's Health on the voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about your heart, how to keep it healthy, especially after dealing with COVID and some new technologies to help your heart if ever it needs it. From Northwell Health here on Long Island, including our new cardiac catheterization lab. My guest today is Dr. Rajiv Jauhar, the vice chairperson and at Sandra Atlas Bass Heart Hospital and chief of cardiology, North Shore University Hospital. So, doctor, could you give us are there some surgeries that exist that you can go in there and actually remove plaque? I mean, does that ever exist where you can, just get rid of the plaque?
No. I mean, you can break it up, you can embolize it, you can push it distal, you can make it into small pieces that sort of go into the capillaries and out of the system. But just by going in and removing plaque and saying you've affected change, no. Once you develop plaque, it's like your kitchen pipes, right, at home. So you put enough stuff down that kitchen sink, and then you go into those pipes 6 months, 2 years, 5 years, 10 years later, there's gook, for lack of a better word, all the way up and down the pipes. When you have a major problem is when you completely close off those pipes, right? Then you have backfill and you have to sort of go in and rotor-root that stuff open. But even when you rotor-root those pipes open, all that gook on the sides is still there. So you're basically affecting change, immediate change to maximize flow. And then hopefully, if it's your arteries to your heart and not your pipes in your kitchen, you are now being aggressive with therapeutics, medications, drugs, exercise, diet, stress relief to sort of mitigate the chance of worsening those pipes. Are
you seeing more and more women with heart disease than we have seen in the past? And can you describe for me why that is?
Absolutely. I'll give you an example. A few years ago, this lady called me and said, I'm having chest pain. And the pain was atypical, right? It was not your classic elephant sitting on your chest, down the arm. And she called me and I said, I think it's okay. And then I called my brother, who's also a cardiologist. I said, just talk to her. He goes, yeah, she's a little anxious. 3 days later, mom had a stent. That was my mom. My dad, who was 10 times healthier than my mom, ran 10 miles easily. One day had chest pain and we called 911. So there's a certain level of sexism in heart disease among women that even I had before mom had the stent. Yeah. So, and why is that? Well, one is because women do not typically present with typical symptoms. That does not mean they don't have typical symptoms, because they do. And many times we'll see that. But the ability for them to present with atypical symptoms is higher, number one. Mm-hmm. Number two, just like my brother and I did, even though we're cardiologists, there is a tendency to sort of push away, to not believe, to ascribe to anxiety, pain that women have. And it's purely sexist, and it's wrong, because we're seeing a dramatic increase as women now have left the home into the workplace. Their anxiety levels are equal or higher than men's. Their development of heart disease is at a rate much faster than what men are going through right now. So for your audience out there, Dr. Cook, I would say that, if for the women audience, if you have symptoms, if you have chest pain, if you're not sure, please go see your heart doctor or see your primary doctor, because more times than not, it may be heart disease. And it may present something quite atypical, like maybe stomach pain or maybe epigastric, pain, and it's not at all chest pain. And so I have another question for you, and the audience may have this question in terms of the correlation between hypertension and heart disease and even kidney disease. Hypertension is the silent killer. You don't feel it unless it's really high or really low. And so people just don't give a damn, right? But hypertension is a risk factor for heart disease. It's a risk factor for stroke. It's a risk factor for dissection. It's a risk factor for kidney disease. And it's much more common among the African American population. That's fact.
Yes.
And so hypertension is really, a lot of it is genetic, but a lot of it is diet-based too. I mean, I have so many of my South Asian patients, my African American patients, and I see them once a year, and I give them the playbook, what to eat, what not to eat. And I'll go to a restaurant, and I saw one at a Lebanese restaurant eating,
they love to see you come in.
And they saw me and they're like, oh boy. And they're trying to hide the food. I'm like, hey, hide the food. But so hypertension is definitely a big issue with
That was really funny. Can you imagine your cardiologist coming in while you're eating a piece of fried chicken? It's funny.
It's like you get caught with a hand in the cookie jar,
How do we get in touch with you? We want more information.
Well, you can call my office at 516-562-4100. Probably the best way to get in touch with me.
Awesome. Thank you for being with us today, Dr. Rajiv Jauhar, the Vice Chairperson at Sandra Atlas Bass Heart Hospital and Chief of Cardiology, North Shore University Hospital. We hope you stay safe and continue to stay healthy. And thank you for being our guest today.
Dr. Cook-Garard, thank you so much for inviting me, and thank you for all you do.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.